Hello, I'm Diana Keogh, Editor-in-Chief of Sherwick.com. Today we're chatting with Dr. Joseph Ricotta, who is a vascular surgeon and Director of Clinical Research at Emory University. Dr. Ricotta has agreed to take questions that have come in over the internet from our members about a new procedure for aneurysms called branched and fenestrated endografts. Dr. Ricotta, I'm going to ask the first question. Tell us exactly who is a good candidate for this procedure.
Any patient with a complex aortic aneurysm is a potential candidate for a fenestrated graft. And by complex, I mean aneurysms that are close to or involve the kidney arteries or the intestinal arteries. Now, sometimes patients who are good risk, healthy patients could have those aneurysms fixed with open surgery, but the majority of those patients have many medical problems and difficulties with their heart, with their lungs, with their kidneys, or other medical problems that would make open surgery increase or high risk, and those would be the patients who benefit the most from a fenestrated or branched endograft.
Who is not a good candidate for this procedure?
The fenestrated grafts are usually reserved for patients who are at high risk. So a young patient under 60 years old, a young patient with a connective tissue disease such as Marfan syndrome or Ehlers-Danlos, who is otherwise a good surgical risk candidate, at this point would not be a candidate for a fenestrated graft, but should probably have open surgery. And the other subset of patients would be high-risk patients whose anatomy is just not appropriate for fenestrated grafting. And that would have to be a judgment that's made based on the patient's CAT scan, but again, that's a minority of the patients.
Dr. Ricotta, this question came in on Facebook. My husband has been living with an abdominal aneurysm for years. Can you explain this procedure to me?
A fenestrated graft is essentially a fabric tube made out of polyester with some stainless steel in it, and it is inserted through the growing arteries, through a puncture in the growing arteries, does not require an incision, up through the aorta, and acts like a sleeve inside the aorta, and blood will flow through the main tube here, and it will exclude the aneurysm, and over time that aneurysm will shrink. The unique thing about a fenestrated graft is that we can treat aneurysms that involve or encroach on the kidney arteries or the intestinal artery without blocking off the blood flow to those arteries. And the way we do that is that we have holes that we make in this tube, and we line up these holes with, for example, on this side, the kidney artery, the intestinal artery, and the other kidney artery, and we line up the holes and we put stents through those holes into those three arteries, and therefore blood will flow through the main aortic tube, and then it will flow out through the stents that are in these holes into the kidney arteries and the intestinal arteries, preserving the blood flow to those organs.
Dr. Ricotta, this question came in over Twitter. Is there a difference in recovery between this procedure and open surgery?
There's a big difference in recovery. Patients with open surgery often stay in the hospital for a week to 10 days to 2 weeks, and even after they're discharged from the hospital, they may have to go to a nursing home or a rehabilitation facility to get their strength up. And after they're discharged from the hospital, the time to recovery back to their baseline, the time to functional recovery is months. With the endovascular repair, the hospital stay is usually 2 to 3 days. The patients walk the day after surgery, they eat the day after surgery, and they walk out of the hospital 2 or 3 days later because the procedure is done just through punctures in the growing arteries, and so there's no incisions to heal from, and recovery time is much, much shorter than with open surgery.
Dr. Ricotta, this question came in on Pinterest. With this procedure, is there really now an aneurysm that should ever be left alone?
So, using this new technology of fenestrated and branched endografts, we're able to treat all aneurysms of the aorta that basically start at the heart and go down to the legs. So technically, there's really no aneurysm that we cannot fix with this technology. The only patients in whom a fenestrated graft should not be attempted, if they're at high risk for open surgery, would be those with a life expectancy less than 1 year. So that's another criteria that I use. So if a patient has metastatic cancer, for example, and their life expectancy may be 4 to 6 months, it may not be worth fixing their aneurysm. But if a patient has a life expectancy greater than 1 year, then I would go ahead and fix that aneurysm, because particularly if it's a big aneurysm with a high risk of it rupturing. because that will give that patient at least one more year of life.
Dr. Ricotta, thank you so much for joining us here on ShareWork.com. This has been great information. If you'd like more on this topic, please go to our website at www.sharework.com.